Today I'm here to make a brief overview of the current ENT parties in Ethiopia. It would have been better if it was presented with my senior colleagues, but they offered me the opportunity, so thank you. So in preparing this presentation, I've communicated with some colleagues from different hospitals, and I've tried to be representative and inclusive. Before I proceed to my presentation, I would like to express my heartfelt thanks to the ENT Plus team for sacrificing your time, your energy, and of course your money for us to help our patients. So thank you very much. And with Assaye Diagnostics, thank you very much for taking the initiative and facilitating such forum, which will be a foundation for future association meeting and so on. And of course, Ekatit Assaye Hospital for taking care of our guests. So I don't have any conflict of interest. And my colleagues, if you have any comment, if you think the data is not representative, or if you think it's incomplete, you can interrupt me anytime, and you can add your comments, or the stage will be open for discussion at the conclusion of my presentation. So when I go to my presentation, I'll have background. I'll try to show how many human resources or any surgeons do we have, and the current residency programs and service providing hospitals and available equipment, and the current service and limitations, and finally the role of ENT Plus or the contribution to this country's ENT development. And finally, I'll try to put my conclusion and way forward, and I will leave the stage for discussion. So when we start here, Ethiopia, most of you, I think you're familiar. Population size is estimated to be around 120 million, and the capital Addis Ababa by itself is I guess to have like more than 5 million. And when you see the distribution, 80% of the population lives in rural area. And our healthcare system is structured into three-tier system. We do have the primary healthcare, like including the health post and the health centers, and we do have secondary level, that is the hospitals, primary and secondary hospitals, and tertiary level of care, including the blood line hospitals like blood line, St. Paul, Ethiopian. So in our country, the system is like a patient can't jump directly to tertiary level of care before visiting the primary or secondary level of care. So when we see the healthcare finance, as most developing countries, developing countries, the health budget is very low, and most of the health service or the sales sector finance comes from the loans and donations from all over the world, with contribution of the government budget only 16.5%, and the rest is covered by many out-of-pocket payments. So insurance systems are not well developed in our country. And when you see the human resource, the total number of ENT surgeons in the country, both private and government parties, are estimated to be 70 to 80, and 30% are in their retirement period, and 20% of them are in sole private practice, and most are domestic trained, few trained abroad from previous socialist countries, from West and from South Africa. And when we see our fellowship trained surgeons, we do have three fellowship trained surgeons, two from South Africa, one from Cameroon. We do have one pediatric surgeon who was training from South Africa. We have one otology and lateral service training surgeon now in Italy. And we don't have neurology, anterior scalpes, we don't have facial plastic, and we don't have laryngologists and so on. So the residency programs in Ethiopia, the ENT hearing neck surgery residency program is a 4-year program. And initially the residency program was started at Addis Ababa University in 2018. And until recently, Addis Ababa University was the only university which was running this residency program. But currently, there are 4 universities, colleges, which are running this ENT hearing neck residency program. One is the Addis Ababa University, the others are St. Paul Millennium Hospital, Medical College, Mekelle University, and Bahar University. So each university takes like an average of 3-4 residents per year. And when you see the service providing hospitals, there is a study which is a survey done in 18 sub-Saharan countries, including Ethiopia. And this study has showed the availability of service was extremely poor, with poor distribution of service, and the service distribution was inequitable, training opportunities were limited, and so on. And currently, infrastructure for ENT hearing neck surgery health service exists in the following government institutions with full-timer ENT hearing neck surgeons. In Addis Ababa, we have Black Lion Hospital, we do have Ekatit Sraulet, Ekatit Medical College Hospital, and Torayot Hospital, which are affiliations of Addis Ababa University. And we do have St. Paul Millennium Medical College. So these two universities, they run residency program. And there is Minilik and Ras Test Hospital. In Oromia region, we have Jimma University and Ayamaya Mahmoud Hospital. In the south, we have Hawassa Comprehensive Specialized Hospital. In Amara region, we have 3 hospitals, Alagarot, Gondar, and Ramadan. And in Tigray, we have one university hospital. So you can see most of the service providing hospitals are concentrated in the center, in Addis Ababa. We don't have that much service providing hospitals in the periphery. And when we see the available equipments, there's no doubt that delivery of this better service is highly dependent on accessibility and functional level of the infrastructure, equipment, and the supplies. So, relatively modern and adequate ENT hearing neck surgery health service equipments are available at either that's Mekelle University Hospital and St. Paul Millennium Medical College. In St. Paul, it's government purchased supplies. All other are lacking modern and adequate service equipments, and most of them are getting these instruments via donations, which happen in few-year intervals. And most of surgical cases are incomplete due to the poor instrument handling and aging. So this is bird's eye view, which I get in the strategic plan of the Minister of Health Ethiopia. Try to review the available seats in these government hospitals in Black Lion, St. Paul, Ekatit. Some may not be truly representative, but they can give us a clue how limited resource we have. And when we go to the current services and limitations, generally there is a great progress which has been made in ENT hearing neck surgery type and volume in the last 5 to 7 years due to young graduates which have this deep interest to expand the service type and volume. There's rigorous self-teaching, and there's experts sharing their knowledge and transferring their skill. ENT Plus is one of them. And foreign professors are involved, especially in St. Paul and Mekelle University Hospital. They have full-time employee of these foreign professors. And we also recently get this fellowship trained Ethiopian. So due to this, there is great progress in ENT service. So to see some services and the details or specifics of the service, the service and the limitations, we start with otology. So while I'm discussing the mainly referring domestic surgeons, okay, not referring the experts coming, performing different procedures and other foreign professors. So in the otology part, as it's known, chronic otitis media is rampant in Ethiopia as other third world countries. So commonly performed procedure is tympanoplasty. And most ENT surgeons are comfortable doing this both microscopic and endoscopic tympanoplasty. Ossicular reconstruction, most of the time, almost always, is autologous grafts, and most of us are comfortable doing mastoidectomy and other procedures like canaloplasty for oral atresia. Have never been done. Stitch surgery, not frequently practiced. If practiced, it's practiced, it's occasional with foreign surgeons and so on. And facial nerve decompression and anastomosis, not a usual practice. And surgical treatment of vertigo, not practiced yet. Paraganglioma surgery, unless it is a limited one like type A and so on, not as such comfortable. Some colleagues do, but not with great comfort. And cochlear implant it's not a consistent practice. And to show you some procedures done, this is mastoidectomy being practiced by one of the chief residents of St. Paul Hospital. So you can see an inside out canal down mastoidectomy done with removal of this orthotomy sac and so on. So I can say most of the young graduates are comfortable doing mastoidectomy. And in Hellenic practice, now I think I can say almost all types of Hellenic procedures are being performed. Okay, we do have fellowship trained Hellenics. The contribution of ENT Plus with regard to Hellenic is immense. They have contributed a lot in teaching domestic surgeons. So it's all salivary gland tumors, advanced upper aerodigestive tumors, neck dissection, tractor resection and anastomosis, thyroid surgeries, with reconstruction, with local and regional flap reconstruction, all are currently being practiced. And the contribution of, again, the Swedish team is immense. Most general otolaryngologists under their training can comfortably do laryngectomy and neck dissection. And the limitations here in Ethiopia with regard to head and neck surgery, we didn't start this pre-flap reconstruction, and there is long waiting time for adjuvant radiation. Okay, so that is a problem. So this is one of the patients who was operated by our head surgeon. This is mucoepidermoid carcinoma with carotid, grade 6 facial nerve paralysis. He had been operated 2 times at Bardar with recurrence, and now he's operated, total paraphyrectomy done with, I think, comprehensive neck dissection and pectoralis major reconstruction of the defect done, and there was deep necrosis of the blood, which was later covered with skin graft, and patient was sent for oncology for adjuvant radiation. And you can see neck dissections and laryngectomies can be easily done. And when it comes to radiology and skull base, so far this is the part of ENT which didn't get any focus so far. So most experts who are visiting us, they do otology, they do head and neck, but not rhinology and anterior skull base. I can say Professor is the first one as a foreign professor and rhinologist, endoscopic surgeon to visit us. And it's a thriving field, endoscopic surgeries, a thriving field. And most endoscopic procedures are performed with self-learning. Okay? So I think in every country, in every field, there are some pioneers, the pioneers of these surgical procedures. In our country, I can say Dr. David with the department of, the head of the department of this Assaye University, in the department, is a pioneer. Okay, he started it like by himself. He teach us how to do it and so on. Now I think we are at least helping our patients in some way. So endoscopy septoplasty is a fairly common procedure, which most of us are comfortable to do. Septal perforation repairs is we do it occasionally with anterioethmoidal artery flap. Endoscopic anthrostomy, ethmoidectomy, sphenulectomies are being performed in few setups, like 2-3, because there is limitation in instrument. Okay, there is a limitation in instrument, and these are performed with variable comfort and perfection. And frontal sinus is being always difficult for most of us, and medial maxillectomy is not as difficult, and juvenile angiofibroma, few cases have been operated endoscopically. We don't have endoscopic clips, we don't have access for embolization and so on, but we have tried, and at least some of our colleagues have tried to do endoscopic juvenile angiofibroma excision. Advanced cases with head and necks have been like maxillary swing and so on, with mid-fascial degloving and so on. Sphenopalatine artery ligation, CSF repair, ENT, neurosurgery, team surgery. We do have very limited practice. And endoscopic diagnosis is handled by ophthalmologists, specialists, open type of procedure. And orbital decompression, optic nerve decompression, and so on, they are not frequent practice. They are not practiced. And craniofacial fractures are mainly managed by the maxillofacial department. And to show some cases, so this is a patient in her 30s. She's a mother of 2 children. She visited our center after 2 weeks of left side nasal obstruction, facial numbness, and darkening of the skin, as well as orbital or eyeball protrusion. She's a patient with newly diagnosed DEM with treatment for diabetic ketoacidosis. So when she visited us, an endoscopy was done, and this is the endoscopic picture of this patient. It's like it appears like a cadaveric picture, all dead, blackout with loss of sensation and so on. and left side, the nasopharynx, the turbinates, the septum, everything dark with necrosis. So this patient was started with IV amphotericin. In fact, we didn't have the liposomal one, and even it's difficult to get the liposomal type of amphotericin here. And she was started on that track. We started, we take her to the OR, and we did endoscopic sinus and nasal clearance. We did orbital exentration, and we did subtotal magnelectomy for this patient. And getting consistent amphotericin B treatment for this patient was difficult. And when she takes this amphotericin B, she gets better. When the amphotericin B is off, the symptoms come back and again, and so on and so on. So she has been in our ward for 2 months with on-end of treatment of this amphotericin B. Finally, she started to be fine, and we put her on fluconazole and we sent her home. We don't have other antifungals which are used for treatment of this mucormycosis. So after 2 months staying at home, she came like this, with complete clinical and laboratory improvement and mucosalization of the denuded bone and so the sphenoid. Septum is completely out, no medial maxilla wall, and so on. She needs reconstruction. So we can say life-saving procedure was done for this patient. And this is an adolescent who comes to us with unilateral nose bleeding, and imaging was typical for angiofibroma, and we did mid-facial deglobing for just vascular access. The tumor has displaced the maxillary sinus medial wall far laterally, and patient after 1 or 2 weeks, he looks like this with good osmotic outcome, but he didn't come again after 2 months and 3 months appointment, which is very typical of our patients. They don't present for follow-up. So rhinoplasties, they are also being practiced by some of our surgeons depending on the interest. This is a rhinoplasty cartilage augmentation done out of Addis by one of the general otolaryngologists. Pediatric surgery, the most frequently performed procedure is rhinotonsillectomy, which anybody of us are comfortable. Implanostomies, grommets, and other consumers are very difficult. Okay, so our importance, they don't have these grommets, gel foam, surgicel, silicone sheets, and so on. They are very difficult to get routinely. We are mainly dependent from donations, donations like from ENT blood and so on. Laryngeal papilloma debridement, we do it with microcap forceps. And hearing neck, congenital cystis, thyroglossal duct cyst, bronchial cleft, they can be easily managed. Airway and esophageal foreign bodies. Here in Ethiopia, there is a mix of practice. Okay, so previously in Geolof Hospital, when there was no pediatric surgeon, we enlisted to be manage this airway and esophageal foreign bodies, but taking over now. And adult airway and esophageal foreign bodies are always managed by ENT surgeons. tracheostomies, there is limited airway reconstruction practice, okay? We don't have that practice. Laryngology, our year one residents are comfortable with direct laryngoscopy, and microlaryngeal surgeries are not well established here. Mostly we do excision with punch of these polyps or cystis or nodules. There is no microflap technique. We are not practicing it most of the time. And thyroplasty, arterial abduction is not a common practice. And balloon dilatations, balloons are not easy to get, but when we get it, we have adequate training from the ENT class. And both injections, laser surgery, not being practiced. And when we see audiology, we do have only one trained audiologist with ENT surgery background. I think in other countries, audiologists, it's just like in bachelor's degree, or they go after this bachelor's degree. But here we have only one trained audiologist. So we do ENT surgeries. We are comfortable with this audiometry, audiometry, and so on. Hearing aids, they are fitted properly by the community, like the family from abroad will send them a hearing aid, they will fit it. Most of them are not comfortable. Okay? They come with like, it has excessive noise, it's not hurting me, so and so on and so on. And they have developed body attitude towards these hearing aids. Tympanometry, autoacoustic emissions, brain response, auditory responses. They are not available in every setup. I think some are available in cell. Otherwise, we don't get them right and left in other government institutions. So, in conclusion, the number of general otolaryngologists as well as fellowship trained surgeons are quite few in number in our country. And even with these services concentrated at the center, and there is limited equipment. Equipment handling is frustrating. Even the equipment we do have, they are aging very fast. They are getting broken and so on. And engagement of experts like ENT Plus has brought significant change. And generally, we can say there is good progress in ENT practice. So what the way forward? How can we make it practice? So these are a few of my suggestions. So later you can suggest a lot of things. Stage will be open. So workshops like this, dissection courses are important, and strong professional associations are important. And more residency training courses and fellowship training should be available, and we should also facilitate knowledge and skill transfer with exchange programs and so on, and engagement of health sector investors in providing these supplies and so on is also very important. So finally, my presentation will be incomplete without mentioning the role of this ENT Plus. I think for those of you who are not familiar with this ENT Plus, these are Swedish based NGO which is established in 2012, and they help patients with ENTs and conditions, and they promote knowledge and skill transfer to local health professionals. And it consists of a team of volunteers, ENT surgeons with different subspecialties, nurses, anesthesia professionals, IT professionals, and so on. So far they have visited Ekatit Theological Hospital more than 10 times since its establishment, and they have done more than 200 advanced ENT surgeries, and they have donated lots of medical supplies, from consumers to major equipment like drill system, operating microscopes, endoscopes, and different sets of instruments. And more importantly, they are transferring their invaluable knowledge and skill, and we are very, very grateful for that. So this is one of the pictures. It was taken in 2019. We were for the residents back then in 2016. So this is the highlight. I think the stage is open. You can mention your practices in other hospitals, then you can add, and you can also give suggestions and comments on my presentation. Thank you.